First, I'd like to thank Chairperson to introduce me and the organizing committee of this conference to invite me in this session. I'd like to talk about the surgical outcome after neoadjuvant therapy in young females with breast cancer. Neoadjuvant chemotherapy is defined as adjuvant systemic therapy administered prior to rather than following operational treatment. It is also known as primary, induction, or preoperative therapy, all of which terms indicates that subsequent treatment is intended. The neoadjuvant therapy is established as therapeutic avenue in breast cancer for selected high-risk breast cancers, tumors more than or equal to 2 centimeters, and for locally advanced disease, including initially eligible for resection. This approach offers the advantages of decreased tumor size, downstaging the disease, potentially reducing the extent of surgery, allowing an increased percentage of women to undergo breast conservation therapy, and in an era of individualization of therapy, testing the efficacy of therapy administered to patients. Meta-analyses have shown equivalent or improved disease-free survival using neoadjuvant chemotherapy. Emerging evidence from subgroup analysis of neoadjuvant chemotherapy trials suggests high tumor grade and young age. Young age may identify subgroups of patients who have an increased benefit from neoadjuvant chemotherapy within the luminal triple-negative breast cancer subtypes. Although breast cancer is the most common cancer in women, only 1% of patients are younger than 35 years old. However, breast cancer in young women considered aggressive and associated with poor prognosis. On the other hand, young females represent a special group of patients have special requirements to preserve breast shape and avoiding the obsession of traditional mastectomy. So breast oncoplastic surgeons should offer all available choices that's suitable for each patient, either conservative oncoplastic volume displacement surgery or oncoplastic volume replacement breast reconstruction. During the last decade, several studies have shown the advantage of immediate breast reconstruction over delayed reconstruction in terms of cosmetic, quality of life, and psychological reports. As regards to the impact of neoadjuvant therapy on surgery, the most common complication associated with breast surgery has been reported to be wound infection. Given that cytotoxic chemotherapy is known to cause neutropenia, it has been hypothesized that neoadjuvant chemotherapy may lead to increased infectious complications. However, recent American College of Surgeons National Surgical Quality Improvement Program study showed no association between neoadjuvant chemotherapy and post-operative wound complications. So in this retrospective study, we aim to assess the short-term surgical and aesthetic outcomes after neoadjuvant chemotherapy in young patients with breast cancer aged 35 years or less. 18 patients with invasive ductal carcinoma were enrolled in this retrospective study. The ages were ranged between 23 and 35 years. Tumor sizes were ranged between 2 to 8 centimeters in the largest diameter. The timing of surgical interference depends on the clinical and radiologic response and was tailored for each patient individually according to MDT decision, aiming for getting the best pathologic response. 13 patients underwent surgical interference after the third cycle, and 5 patients completed the 6 cycles of neoadjuvant chemotherapy course. Pathologic complete response defined as no microscopic evidence of any residual malignant disease, including ductal carcinoma in situ and the primary tumor site of lymph nodes at the surgical excision. No response or progression means lack of clinical response or progression during the primary chemotherapy treatment, resulting in change in the planned chemotherapy regimen. And partial response means all patients not having no response or progression or pathologic complete response. The pathologic complete remission is a valid surrogate of long-term survival and cure for breast cancer. From breast cancer, in clinical trials of neoadjuvant chemotherapy, pathologic complete response have ranged from 6 to 26%. And 4 factors were associated with pathologic complete response: higher tumor grade, lack of estrogen receptors, progesterone receptors, expression of HER2 amplification, and negative lymph node status. The integrated meta-analysis on individual data from the German breast group and AGO breast group provides information on 6,402 patients enrolled in the adjuvant trials containing doxorubicin or ibrubicin, docetaxel, or paclitaxel with or without trastuzumab. This has shown that ER-negative patient had a greater chance of pathologic complete response than the ER-positive patient. Furthermore, HER2 positive disease, high-grade tumors, younger age, non-nuclear type tumors, and smaller tumor size were also significant predictors for pathologic complete response. In our study, the pathologic response results were 1 patient with triple-negative breast cancer showed complete pathologic response, and the 15 patients showed partial response, and 2 patients showed stationary course. When we discuss the surgical procedures, 13 patients had conservative or spheric mastectomies with immediate breast reconstruction. 5 patients with retroperitoneal or central cancers had skin-sparing mastectomy, and 8 patients had nipple-sparing mastectomy. 4 patients with low-grade invasive ductal carcinoma whose age were 30 to 35 years had oncoplastic conservative breast surgery, and 1 patient refused any oncoplastic procedure and preferred to have the traditional modified radical mastectomy. This patient, aged 33 years, presented with malignant mass in the right breast about 30.5 per 30.4 centimeter, radical duct carcinoma, grade 2 ER, PR positive, HER2 negative. She received 3 cycles of FAC with partial response. We plan to do a nipple-sparing mastectomy through this incision running along the anterior axillary line with infero-lateral incisions to evacuate the whole breast parenchyma through this incision, and this is the bed after complete parenchymal excision, and this is the spacement with axillary lymph node dissection of level 1 and level 2. It showed the positive 3-pair 10 dissected axillary lymph node. Here we transferred the latissimus dorsi from the back and through the axillary tunnel into the bed of the breast remote to reconstruct the breast mound. And this is the 2 weeks after the operation with good healing without any wound complication. And this is 1 year after the operation, and this is the mammography for routine follow-up. The same patient, 2 years after operation with back incision with good healing after the primary and secondary suture and mammography for routine follow-up. Another case, young patient aged 35 years with right congenital nipple inversion, presented with mass 2.5 per 2 centimeter at 7 to 8 o'clock, invasive ductal carcinoma, grade 2, ER and PR positive, HER2 negative. She received 3 cycles of FEC with partial response. We plan to perform a G-shaped mammoplasty through a comma-shaped incision. Here, this round-the-clock periareolar incision. Here we resect the whole tumor with safety margin. And this is a bit after resection with the epithelialization of the periareolar incision. And this is the final closure. And this is patient 3 weeks with excellent aesthetic outcome without any wound complication. And all 9 dissected axillary lymph nodes were free. Another young woman, aged 24 years, with multicentric triple negative high-grade infiltrating duct carcinoma. The largest masses measured 2.6 per 2 centimeter and 1.9 per 1.4 centimeter. She completed the 6 cycles of the neoadjuvant course with partial response. Here we plan to perform what is called the nipple sparing skin reducing mastectomy through inverted T incision. Here we resect the whole breast parenchyma with with part of the skin to reduce finally the skin envelope. And we did the epithelialization for the round block incision, and here those 2 triangles also we do the epithelialization. Here we transfer the latissimus dorsi from the back to reconstruct the whole breast, and finally we closed the incisions through this inverted T incision. The patient showed mild wound edge ischemia with wound dehiscence, and we managed this patient conservatively, and this is 2 months after the operation with good aesthetic outcome. In our study, the most common post-operative complication was wound edge ischemia and dehiscence. It was occurred in 5 patients with sparing mastectomies and immediate breast reconstruction. 3 of them were managed with debridement and second suture, and 1 patient with conservative breast surgery in the form of lateral mammoplasty, and she was managed conservatively. Seroma at the donor site of latissimus dorsi was occurred in 4 patients with immediate breast reconstruction, and it was managed conservatively by repeated percutaneous aspiration. Backbone suture line failure occurred in 2 patients. 1 needed debridement and secondary suture, and this is the photo 2 years after the operation, and the other was managed conservatively. However, there is no major complications requiring repeat surgical intervention. This may be attributed to 2 factors. The first factor, our accumulated learning curve of experience in immediate breast reconstruction for a series of 500 patients without prior neoadjuvant therapy, which started 10 years ago in Oncology Center, Mansoura University. And this is the earlier publications of this series since 2007 till now. The second factor is a strict proper choice of surgery timing with after 2 to 3 weeks after the last cycles of chemotherapy. As regards to the aesthetic outcome for patients with incoplastic procedures, after exclusion of 1 patient with modified radical mastectomy, the subjective patient satisfaction was excellent in 12 patients, and good in 3 patients, fair in 1 patient, and poor in 1 patient. The main follow-up about 13.5 months. In conclusion, neoadjuvant chemotherapy yields good oncologic response with satisfactory surgical and aesthetic results, and low morbidity in young patients with breast cancer. Another prospective study is recommended in order to evaluate the long-term oncologic outcome and survival in those young patients with breast cancer. Thank you.
Thank you, Dr. Omar. And we shift to the next presentation. Detection of different genotypes of human cycling virus in breast cancer patients by Dr. Sarla.
invite me to this big conference. Today I will talk about detection of different genotypes of human cytomegalovirus infection in breast cancer patients. Human cytomegalovirus is one of the members of beta herpes associated with a wide spectrum of disease, has a broad spectrum of infectivity as documented by the various different cell types that can be infected in vitro and by the multiple organ tropism observed during infection in vivo. Differences in tissue tropism as well as differences in the severity of clinical manifestations and in the ability of cytomegalovirus to establish resistant or latent infection have been proposed to be related to a genomic variability among strains. The past 30 years, cytomegalovirus was pathology of several malignancies, including colon carcinoma, Kaposi sarcoma, cervical carcinoma, prostate adenocarcinoma, glioma brain tumor, and breast cancer. The oncomedullatory effects of human cytomegalovirus infection in tumor cell biology. Cytomegalovirus is not considered oncovirus, but it has the ability to modify tumor cell biology independently from transformation, so it's categorized as oncomedullatory virus. It can modulate apoptosis, stop the apoptotic pathway in the infected tumor cells, and also modulate cell migration, increase the cell migration, and by the way, the metastasis, and also modulate angiogenesis. We make a viral screening to the most common viral infection in breast cancer patients here in Egypt. Here we detect the cytomegalovirus infection, the human papilloma virus type 16, Epstein-Barr virus, human herpes simplex virus type 1, and the human herpes simplex virus type 2, and human herpes simplex virus type 8. Our results show that human cytomegalovirus infection was the most prominent viral infection in Egyptian breast cancer patients. Our results of the PCR test show that we have different strains in IBC patient versus non-IBC patient, and so we start to ask ourselves why. This is the first question, and our results show that the viruses present in the tumor only, not in the surrounding normal cells. Our explanation, this is maybe the immunity inside the tumor area was very low, so it has become very good environment to the virus to make a chilling here. Human cytomegalovirus glycoproteins, cytomegalovirus is an enveloped virus, are usually considered important target for neutralizing antibodies, and they can induce strain-specific antibodies. Human cytomegalovirus glycoprotein play an important role in virus entry and cell-to-cell virus spread. These viral proteins has also been shown to exhibit genetic polymorphism. In our screening, we detect two types of glycoprotein B and the glycoprotein N. We have 5 genotypes of glycoprotein B, glycoprotein 1, 2, 3, 4, 5, and 4 genotypes of glycoprotein N. Glycoprotein N3 and 4 have a sub-genotypes for glycoprotein N3, glycoprotein N1, and the glycoprotein N3B. And for glycoprotein N4, we have 3 sub-genotypes, the glycoprotein N4A and 4B and 4C. For glycoprotein N, we found that glycoprotein N1 was the most prominent genotypes in IPC and non-IPC patients, but the frequency of genotypes in IPC patients, glycoprotein N1 was the most prominent, and then glycoprotein N4, then glycoprotein N3, and finally glycoprotein N2. In non-IPC patients, glycoprotein N1 was the most one, and then glycoprotein N4, glycoprotein N2, and the glycoprotein N3. We detect the full gene sequence of the glycoprotein N, and we published this sequences of the 4 different genotypes on the gene bank with 4 accession number. Then for glycoprotein B, also glycoprotein B1 was the most prominent genotypes in IPC and the non-IPC patients. The frequency of glycoprotein B genotypes was glycoprotein B1 and the glycoprotein B3, glycoprotein B2 and the glycoprotein B4, and B5 and the glycoprotein B4. In non-IPC patients, glycoprotein B1 was the most prominent one, and the glycoprotein B3, and the glycoprotein B2, glycoprotein B4, and the glycoprotein B5. The mixed infection between different genotypes for glycoprotein N, we found that IPC patients characterized by high incidence of mixed HCMV infection genotypes infection. Here in IPC patients, we found that the mixed infection between glycoprotein N1 and the glycoprotein N2 was the most prominent one, then glycoprotein N1 and the glycoprotein 3B, and finally glycoprotein N1 with glycoprotein 4B also. For non-IPC patient, we found only 2 types of mixed infection, glycoprotein N1 and the glycoprotein 3B, and the glycoprotein N1 plus glycoprotein 4BC. The same amount for glycoprotein B, IPC also patients characterized by high incidence of mixed HCMV genotypes infection. In IPC patients, we found mixed infection between glycoprotein B1 and the glycoprotein B3, also glycoprotein B1 and the glycoprotein B2, glycoprotein B1 and the glycoprotein 4. In non-IPC patients, we found that glycoprotein B1 plus glycoprotein 3, and the glycoprotein B1 with glycoprotein 2, and the glycoprotein B1 with glycoprotein 4. Our conclusion, cytomegalovirus was the most prominent viral infection in Egyptian breast cancer patients. Also, cytomegalovirus oncomodulatory effect increased breast cancer aggressiveness. Human cytomegalovirus infection, glycoprotein N1 and the glycoprotein B were the most prominent genotypes in IPC and the non-IPC patients. In IPC patients characterized with high incidence of mixed cytomegalovirus infection genotypes. And finally, I want to thank all members of the Cancer Biology Research Lab, and especially Professor Dr. Muhammad Shinawi and Professor Dr. Mona Mustafa. And thank you.
Thank you, Dr. Hussein. That was the last presentation. The floor is open now for questions.